We'll get started in just a moment. We're just waiting to let people in from the waiting room. Great, I think we can get started. Welcome everyone. I am Babette Henderson. I am the Senior Director of Alumni Engagement for the Feinberg School of Medicine. And I'd like to welcome you to our webinar, The Evolution of Preventive Cardiology. We've had many pre-submitted questions for this event, but if you do have a question, please use the Q&A section to ask the question, and time permitting, we will be able to answer additional questions. This webinar is a kickoff event for the Half Century Club. Our Half Century Club recognizes our alumni who graduated 50+ years ago and celebrates your dedication to the betterment of human health. We will be planning many webinars and events going forward, including special programming at Alumni Weekend this April. We will follow up with information after the webinar with a link to our Half Century Club benefits. And please do reach out to me with any questions. I would like to introduce one of our Half Century Club committee members, Dr. Andrew Klaus, a retired cardiologist who graduated from Northwestern's medical school in 1966. Dr. Klaus will introduce our event moderator, Dr. Donald Lloyd Jones. Dr. Klaus?
Thank you. Good evening. It is my distinct privilege to introduce the moderator of this inaugural event, Dr. Donald Lloyd Jones. He is the chair of the Department of Preventive Medicine, professor of heart research, and professor of preventive medicine and pediatrics. His research interests are the study of the mechanisms of cardiovascular health and healthy aging, including cardiac epidemiology, risk estimation, and prevention. He is a practicing clinical cardiologist focused on prevention and will serve as president of the American Heart Association for 2021-2022. Dr. Lloyd Jones, thank you for being with us tonight.
Thank you so much, Dr. Klaus. It's really a pleasure to be with this group of our most distinguished alumni. And I want to thank everybody for joining us tonight. It's really a pleasure to have you all here. We're really excited about the questions that you all have submitted and getting the opportunity to address those. What we're going to do tonight is celebrate the legacy of Dr. Jeremiah Stamler, which we heard from all of you was something that you wanted to hear more about. And so we're going to have an opportunity to really dig in on Jerry's legacy, but do so in the context of thinking about the evolution of preventive cardiology from really the 1960s to today. And so I'll be introducing our panelists in just a moment, but we've got some distinguished panelists who will help us kind of work through that legacy and work through the evolution of preventive cardiology as we go through this evening. We thought it would be fun, though, to start with a video that was produced about the life of Jerry Stamler just a couple of years ago. In the fall of 2019, Jerry turned 100 years old, and we had the opportunity through the medical school to celebrate his 100th birthday and to invite many, many people to come to Chicago who had been his friends and colleagues during that incredible career. And for that really wonderful event, we produced a video to talk a little bit about Jerry's legacy. So we thought it'd be fun to start tonight with this short 4-minute video to reintroduce you to Dr. Stamler, or perhaps introduce you for the first time to this really living legend of cardiovascular epidemiology and prevention. So Catherine, I'll ask you to go ahead and play that video if you would.
Etiologic factor cannot be diet, and there's very little evidence to support the view that there is any connection.
Diet is one of the key factors in the contemporary epidemic, and that to end this epidemic, we must do something about the diet.
Jerry has been a paradigm shifter his entire career, and I think much of what he has done in defining new fields and in defining new techniques and methods for measuring human health, it's been an uphill battle probably the entire time, convincing people that diet is an important factor for health.
I began to work in experimental atherosclerosis and in research in 1948. I came to Chicago to work in animals, feeding cholesterol and other things to chickens, and there were dramatic effects in chickens, and we decided it must also be true in humans. And we worked through the Heart Association and through the federal government to get the information out to doctors and to get it out to the public.
As we were emerging from World War II, the story of health and population health was just emerging.
Experts on food emphasize the importance of balanced diet.
But it was very clear already that the problem of the rest of the 20th century was going to be chronic diseases of aging, cardiovascular disease, cancer. But he and his contemporaries really defined this field of cardiovascular epidemiology, and then once we understood what the causal risk factors were, we could move forward then to trying to think about prevention.
What stages of your career these are drawn from?
So Jerry started this department back in 1972. Here we are 47 years later, and it's remarkable how much his legacy endures. Just in the last year, he and his team, with Jerry leading the way, published what I think will be viewed as the definitive paper on dietary factors and blood pressure.
Tens of millions of people with high blood pressure walk in the streets untreated, more than half of them unidentified. That's not exactly a thoroughgoing and comprehensive approach to the health of the people.
I don't know how many other people at the age of 99 have an active NIH R01 grant, but I gotta believe that the number can be counted on, one hand.
As the years have gone by, I've become more and more convinced of the importance of lifestyle for health. What we eat, what we drink, how we work, how we enjoy our families, how we enjoy our holidays.
He had a good sense of humor, and he liked things that I liked, the relationship and the warmth between us. That was what was special.
Oh, she's highly companionable. It's almost impossible to research, very difficult. But I'm convinced it's important.
Jerry is a humble man, and it would take a long time to list all of the things that will mark the legacy that he has created in science. Science is always a full contact team sport, and Jerry would be the first to admit that, but I think most of the good ideas that happened in the development of this field were probably his.
A scientist who selects his own greatest contribution is a foolish person. I leave it to history.
Thanks so much, Catherine. I hope that you all enjoyed that video as much as we do every time we see it. And, it's so great to see the twinkle that's still there in Jerry's eye. And I will tell you that he continues to edit our manuscripts with a very keen eye and precise pen. And so he's still very much in the game. Getting a little bit frailer, but nothing wrong with his mind. He is still the amazing scientist that he always was. So with that, we're going to transition to the next part of the program where we're going to discuss the evolution of preventive cardiology. And again, some of that will involve Jerry's legacy, of course. And so I'm really thrilled to be able to introduce our two panelists. First, I'll introduce Dr. Neal Stone. Dr. Stone is known to many of you. He is actually a member of the Half Century Club, having been a graduate. His MD was received from Northwestern in 1968. And after doing his residency in Boston at the Brigham, he returned to Northwestern, did his cardiology fellowship, and has been on staff as a faculty member and really leading clinician ever since. Many of you know Neal, I hope, but he really is the quintessential clinician and the quintessential curious clinician. So much of what he sees in the clinic drives questions that he feels he needs to answer that have given us insights on things like familial hypercholesterolemia and so many other of the risk factor issues that we've needed to learn about in order to prevent cardiovascular disease. Neal is a mentor to generations of clinicians, of faculty, and of medical students, and certainly has been a mentor for me. And when I get to carpool in with Neal, I always pick up the pearls that he drops because they're just so wonderful. And his experience and his understanding of the science really are unmatched, and certainly unmatched in coming together in a single individual. Because of that breadth of knowledge, Neal has been a real leader in cardiovascular clinical practice prevention guidelines for the American Heart Association, American College of Cardiology, and also, of course, for the NHLBI. So it is a real treat to introduce Dr. Neal Stone. Neal, welcome to the panel.
Thanks, Don. It's great to be here.
And I should mention that about 10 years ago, Neal was invested as the Robert Bono Professor of Medicine. So he has an endowed chair, and we're really thrilled to have you here, Neal.
It's great to be here, Don.
Also delighted to introduce one of our junior colleagues, our true superstar, one of our junior faculty, Dr. Sadia Khan. Sadia graduated from Northwestern as well in 2009 with her MD degree and received a master's degree from the graduate school in 2014. And really has been a driving force among our junior faculty in establishing a research program around prevention. And her particular interests, I think, are around prevention of heart failure and use of newer tools, precision medicine tools, including genetics, to understand just who is at risk for development of cardiovascular disease and specifically heart failure. She is an astonishingly productive investigator and a great friend and colleague. And Sadia, thanks so much for joining us tonight.
Thank you so much for that kind introduction. And it's a privilege to share the Zoom or stage with both of you.
Absolutely. Thanks so much. Well, Neal, maybe I'll turn to you first. You were actually a student of Jerry Stamler's, and I wonder if you have any favorite memories or pearls that you recall from your time with him.
Yeah, one that comes to mind right away is when I was a senior student, I was late to the outpatient clinic where I was assigned as a senior student for a 4-week rotation, I think it was. And they said my colleagues, students said, all the hot clinicians have been taken, Neal, you're going to have to be with Dr. Stamler. And in walks Dr. Stamler, and he didn't have a stethoscope around his neck like the other people did. And I thought, boy, I'm ready for cardiology. What's going on here? And we saw this first case together. And they actually, the guy said, someone said I've got a really high cholesterol. And he said, Neal, what do you know about it? And so I started to tell him about the genetics that I was interested in, about people with inherited high cholesterol. And Jerry said, Neal, you need to look deeper at this guy. He just looked at him. And as we talked it over, and he said, start doing the physical exam. And he sort of kibitzed with me. We end up deciding that he had hypothyroidism. And the reason he had a high cholesterol is that he had a very low thyroid, and concluding with the knees on a chair and clicking the reflexes that were very slow to recover. And that's when I realized the important lesson: don't jump to conclusions about something. And that was Jerry, very, very thorough, very introspective about what's going on. And he became a mentor to me. And when I was chairman of the nutrition committee of the American Heart Association, I had to face a grilling from critics of the diet heart hypothesis. And Jerry gave me some good advice then. He said, never let them hang you on one study. It's the entire body of knowledge that is so impressive. Always talk about all the studies, not just a single study. Anybody can twist a single study, which he added oftentimes a study not that well done. And that was great advice too. So those are some of the things I think of, Don.
Yeah, not too shabby of a clinician and always a great thinker. Thanks for sharing those memories, Neal. That's really wonderful. So as we mentioned, you graduated in 1968 with your MD, and as luck would have it, that was actually the peak of the cardiovascular disease death rate. And we've seen really nice declines over the ensuing 50 plus years in cardiovascular disease death rates in this country. And a number of things have kicked in that, I think you have seen over the course of your career, particularly, and I want to start by talking about what I'll call tertiary prevention. That is, patients who've arrived at the hospital in the throes of an acute myocardial infarction or maybe a stroke. And, initially those people would be put to bed, right? But as over the course of your career, we've had increasing tools to be able to first avoid sudden death, and then later on actually preserve heart muscle tissue, preserve brain cells during those acute events, and obviously drive to much, much better outcomes. I'm thinking about things like the introduction of coronary care units in the late 60s, early 70s, followed by aspirin and, beta blockers and other things. I wonder if you could reflect on that evolution of tertiary prevention across the course of your career.
Well, when I was a senior student, I spent 3 months with Dr. Oglesby Paul at Passivan Hospital, who was one of the greats. He, like Dr. Lloyd Jones and Dr. Yancey and Dr. Bono, was one of the presidents of the American Heart Association. And so Northwestern has a wonderful legacy of presidents. And Don, we're so thrilled that you're the president now.
Thank you.
Such a great thing. And Dr. Paul would talk about we needed to do more to help people, because at the time we were just watching, literally in retrospect, the natural history. And then all of a sudden, when I was at the Brigham, we were under the influence of people like the late, great Dr. Bernard Lown, who used to give lidocaine and pronestal to ablate PVCs, until someone said, maybe that's not such a good idea. And so we started in cardiology the idea of these randomized controlled trials. And we found out giving drugs to knock out PVCs was not such a good idea. And that was the seminal trial, I thought, that told cardiologists, it's not how much gray hair a person has, but it's whether they have a randomized controlled trial. And so as a result, cardiology was replete with these randomized trials that brought us thrombolytic therapy first to help people in the field, then angioplasty, and to the point where, as I remember in the 80s, seeing so many people in cardiogenic shock. We had whole teams that were dealt with cardiogenic shock. We don't see it the way we used to see it then, because today so-called STEMI, ST elevation MI, gets aggressive, prompt treatment. Arteries are opened and people get to have their lives back. It is astounding. And it was all done by these careful cascade of these clinical trials. And then, of course, the trials that told us that even when the arteries open, I remember being an intern at the Brigham and hearing an attending there, this was Harvard, saying, once you've had an MI, you don't need to worry about cholesterol because the cow's gotten out of the barn. And I also remember Jerry Stamler saying cholesterol was just as important at every stage, and because it had to do with atherosclerosis. And in fact, Jerry was right again, because we now had trials like the 4S trial that showed us that using statins to treat secondary prevention patients with an MI could make a huge difference. And our clinical guidelines now talk about using additional drugs like ezetimibe or PCSK9 inhibitors to further lower LDL in those who've had coronary events. So it's been a rich history where we've been able to actually know that cholesterol was a problem, think about diet for primary prevention, but then even go farther with these great tools in secondary prevention.
It's a great point, Neal. And I think your perspective, again, having led so many of the prevention guidelines that deal with tertiary, secondary, primary prevention approaches to people in those different categories. I mean, it's amazing when you get a chance to dig into the evidence the way you have, to synthesize it and to turn that into clinical practice recommendations, right? And you alluded to this, I think in some senses we became the beneficiaries, but also the victims of our successes, right? As more people survived their heart attacks and strokes, we needed to make sure that they didn't have those recurrent secondary events. And so secondary prevention as a concept was really born. And as you pointed out, along came the statins, along came ACE inhibitors, right? To prevent the remodeling of the heart, hopefully prevent subsequent heart failure and other events that can occur afterwards. But it's not always easy, right, to get those things implemented in the patients. And again, wearing your guideline hat, I wonder if you talk about some of the pros and cons of trying to get patients onto what these days is a cocktail of 5 or 6 medications after their heart attack to try to prevent a second event. And if you could talk a little bit about some of the barriers that you see in practice.
Yeah, well, I think the biggest barrier is that when you're sitting there talking to the patient, you may think you're alone, but right next to the patient is the internet. and Dr. Internet looms his head into the conversation. And I like to quickly point out to people when they tell me, you know, doctor, I've done my research and that I've heard that these statin drugs are no good for diabetes. They're no good for people with kidney disease. They cause all these problems. And I go, well, which part of the internet are you reading? Is it the one that's 50% wrong, or the 50% that's wrong, or the one that's 50% that's correct? And I said, I was involved in guidelines where we reviewed not one, not 100, but thousands of studies in a systematic way. We spent years doing it, study after study after study. There's never been more compelling evidence for secondary prevention. The aspirin, sometimes dual antiplatelet therapy shortly after an angioplasty, the beta blockers, the statins, the ACE inhibitors, or the ARBs, we call them. Now we have new drugs in diabetes that are just blowing everybody's mind because they also are important. They make a difference. And so the real question I tell people is, do you really want your care to be like yesterday's care when we didn't do such a great job with a significant number of people? Or do you want to be like tomorrow's care where we do an ever increasing job? And I'm 76. I'm a grandfather for 8 little urchins that I just love. And I really want the science to grow because frankly, I've got a vested interest in trying to hang around. I want to see them grow up. And we're not gonna, and I'm not gonna, the odds won't be as good if I depend on yesterday's care, but they will be if I depend on tomorrow's care. And that's what we have in cardiology. And Don, you've been at the forefront of a lot of the research. And I think what's great about Northwestern, this isn't the place I graduated from in '68. We had great people, but we didn't have the depth and the commitment to really meaningful research that we now have at Northwestern. And at the end of the day, that's going to make tomorrow a better day for all of us.
Wow, great ad, Neal. I hope we can bottle that and use it on the internet and other places too. I completely agree with you. You know, I came to Northwestern in early 2004 when I think we were really seeing an inflection point from transitioning from a really, really terrific clinical medical center and adding that extra layer of really stellar academic, medical research on top of it. And I think we really are earning our stripes now as a top 10 medical center in the country. And, you see it in the growth of our research awards from the NIH. You see it in the impact of our faculty that are, in these guidelines, in all of those other important scientific documents, and really shaping the care we can give to our patients across the world, which is really a remarkable thing to see. And I credit the leadership of the school for really stellar recruitment strategies, but also building the infrastructure here that is needed to drive that research enterprise. And I think it's been a really wonderful thing. If our listeners have not been on campus recently, just a short 1.5 or 2 years ago, we opened the largest single biomedical research building in the country, right here on campus, on the site of the old psychiatric and women's hospital. But it is a remarkable facility, and at 12 stories high, it's already the largest biomedical complex. We are already making plans to build the additional 15 stories on top of that base, and help that to grow our research infrastructure as well. So exciting times for sure. Sadia, maybe I'll turn to you if that's okay. So we've kind of talked a little bit about tertiary prevention. We've talked about secondary prevention. What has come next is the ability to actually think about who is at risk for developing cardiovascular disease or stroke in the first place, or heart failure in the first place. And we've really seen an evolution of how we think about those people, identifying them, whether or not they have risk factors. And we now have a lot of kind of tools and medications in our armamentarium. But let me start with the basics. do you still think that lifestyle has a role to play in the primary prevention of cardiovascular disease?
I think we wouldn't be here talking about the legacy of Jerry if that wasn't the case.
Yeah.
And the cool part about lifestyle and talking about diet and activity and these factors or health behaviors is that it really transcends these different stages that you outlined, right? Tertiary, secondary, primary. And it's the cornerstone of heart health across those stages. And we know it makes a difference at every level. Perhaps at the population level, we're going to get the greatest bang for our buck if we really focus before risk factors are present at that earliest stage or primordial prevention. But on an individual patient level, when we're talking with our patients, we know what a difference it makes whether somebody already has a risk factor, whether they've already had a heart attack or have heart failure, especially in their disease progression, their symptoms, and their quality of life. And so spending time thinking about how even small changes in someone who has heart failure can make a huge difference in how they're feeling and how they're doing. So I know that was a layup to talk about lifestyle, but of course, I think making sure that we know that it's not a lost cause, no matter who the patient is in front of us.
Yeah, I think great points, right? It always has to start with lifestyle, no matter what stage of the disease process, whether they're fully healthy, already have risk factors, already have disease, or or are recovering from some sort of acute event. It's always going to be the bedrock. But beyond that, we do have a lot of medications, and it can get tricky, I think, particularly in an asymptomatic person, right, where they don't yet have disease, but we're maybe recommending a medication that they use in order to prevent the onset of cardiovascular disease. So it's a probability that they could have an event. It's not a certainty, and they don't yet have the disease. So I know we've developed these kind of risk scores that we use in practice, and increasingly we have more and more tools from genetics, from imaging, from biomarkers. Can you help us kind of make sense of how we use those tools in practice in the primary prevention setting?
Yeah, I'll shift to one of my favorite phrases that I picked up. I know you mentioned that Neal is the Robert Bono professor. So when I was a fellow, I was in clinic with Dr. Bono. And one of the things that he said to many of his patients that I've loved and have always picked up is, we don't have a crystal ball. We can't tell the future about what might happen, but we do have a lot of great tools at our disposal to try to quantify these estimates. And I think one of the most exciting things about risk prediction or risk estimation, trying to put some numbers, which aren't perfect because we're not going to be able to tell the future, but give us some information to empower our patients and inform the guidance that we provide in really patient-centered and in patient-clinician informed decisions. So if we're talking about someone who may have a 20% risk of developing a heart attack in the next 10 years, that's not a small number. And what are the things that we can do, and laying out in a step-by-step manner when we superimpose therapies to lifestyle, how we can approach that as well. And so I think that's really kind of the overall paradigm shift that we've been thinking about, is more information can be better. And as we start, we use a lot of the available risk factors: blood pressure, BMI, glucose levels. And I think those are a great place to start. But we know that we can think about a lot of other conditions that may enhance risk. So especially in women, a lot of the women that I see asking about age at menopause, pregnancy complications. We know that these are specific factors that are unique to the women that we're seeing that may enhance their risk for heart disease. And we need to make sure we're talking about it as well as we personalize these discussions.
Yeah, such a great point. Thinking about the whole history of the patient, as you pointed out, reproductive factors that aren't in those risk equations, but actually, if we then consider them, might help us think about shading that risk estimate up. And some of the other things, maybe some of those chronic diseases and chronic inflammatory diseases, things like lupus, rheumatoid arthritis, that can certainly play a role as well. Chronic kidney disease, the list goes on and on. But I think it is really important to put that risk in the context of the whole patient, as you're saying. Lots of other tools, though. So we can actually, fully genotype someone's entire genome today. And what's the current use of that kind of information, and what do you see it being for the future?
It's It's been really exciting practicing today in terms of the resources that we have and the explosion of genetic testing and being able to help inform not just the patient in front of us, but the entire family's risk for heart disease and be able to provide care and really a family aspect to this. We've really seen an explosion in direct-to-consumer genetic testing as well, seeing patients bring in their reports from a whole bunch of companies that are doing genotyping and genetic testing. There's a lot that we still don't know. I think the exciting parts are that we can better identify the cause of heart disease in individual people, specifically for, like Neal had mentioned earlier as well, familial hyperlipidemia or hypercholesterolemia, cardiomyopathies, aortopathies, and aorta and vascular diseases. And thereby identifying the cause, we can actually test family members that may have up to a 50% chance of having a disease. Now, a lot of my patients sometimes ask, why is that important? If I'm already destined to have this, or if I already have this disease, why would knowing this help? And it actually goes back to that lifestyle, that root question that we started this discussion with, because we can still make a difference. It's not inevitable. It may lessen the severity, it may prevent or postpone the onset. And I think that's a really important aspect of what we're trying to do, because if you develop cardiomyopathy at 80 instead of 40, that's a big difference.
You know, a thread running through your points, Sadia, which are really wonderful, is that sharing of information with the patient. Neal, I want to bring you back in here because you're someone who's really published a lot on the process of shared decision making, how we impart information to the patient, how we help them process it, and how we get them to, the point where they feel comfortable making a decision about, let's say, starting a medication for prevention, or making some other choice, perhaps to lose weight or change their diet. Talk a little bit about the process you go through with a patient to try to motivate those kinds of behavior changes or adherence to a medication.
Yeah, well, I use a lot of what you might call motivational interviewing, where you try to establish rapport with the patient first of all, and you find out what makes them tick, and it doesn't take long, where they tell you a little bit about themselves, and then talk about their goals. What do they hope to find? And then now you get a difficult part of the conversation, because this is where it's called cognitive dissonance, where you say, gee, you're such a great guy and you've got so much to live for and you're doing all this, but yet your lifestyle is not the kind that's been shown in study after study to make a difference. How do you equate that? Any thoughts about what could happen? And then sometimes patients actually will say, maybe I could make some changes. I said, well, I'm just be curious, what changes could you make? And invariably they tell me what we're going to do, because at the end of the day, I like to tell the students about the riddle: how many behavioral psychologists does it take to change a light bulb? And the answer is one, but the light bulb's got to want to change. And only if the patient wants to change are we going to make any headway. And sometimes by having people send in a diet diary so I can get an idea of what they're eating. And you don't have to be a dietitian. You can quickly see that the double bacon cheeseburger doesn't belong on the Mediterranean style diet you would hope that they would follow. And in fact, there's often the ability to merge the qualities of both a diet low in animal fat and high fat dairy products and processed meats with a Mediterranean diet. So the two can work together. And so I try to get the patient involved in terms of what they think they can do. And sometimes I'm impressed with how much benefit they can get. And I point out that even if they need a statin drug, being on a better lifestyle will improve the efficiency of the statin. So maybe they don't even need a high intensity statin. And I have many patients who on a really a moderate intensity statin with a fabulous diet, we're doing better than people given high intensity statins. So interesting, and the patients really reap the benefits.
Thanks, Neal. And Sadia, I want to give you the last word during this part of before we get to the Q&A. You've been a real proponent of these new kids on the block, the SGLT2 inhibitors. And I wonder if you could talk a little bit about where they came from, what the benefits are that perhaps were unexpected in terms, at least of the magnitude of the benefit in cardiovascular prevention, and what the future is that you see for them.
The most exciting part about the SGLT2 inhibitor story is the fact that it was really kind of coincidental that we identified the cardiovascular benefits. In prior decades, diabetes trials didn't look at cardiovascular outcomes. And there was a drug, rosiglitazone, that actually seemed to be harming patients and causing more heart failure, even though it lowered glucose levels. So the FDA put together a recommendation or mandate that all trials investigating diabetes drugs had to look at cardiovascular outcomes. And that's where the story of the SGLT2 inhibitors came from, because when they were first being developed, it was really to lower glucose. And turns out they lower glucose a little bit, but they prevent a whole lot of heart failure. And that really has been the story of the last 5 years. And in addition to that, and maybe partly part of the reason they are such a good drug at preventing heart failure, is they also protect kidneys. And so that benefit between heart failure and kidney function, and probably are the first drug ever to improve kidney function and be a kidney specific drug, that I think is really exciting. And you and I have talked about this before, and as we've seen the evolution of statins be really the drug of the 90s, that I think perhaps the drug of the 2020s are going to be these SGLT2 inhibitors or flozins, which may quite be the statins for heart failure prevention that we need.
How do they work, Sadia? Can you just briefly talk about that?
Yeah, of course. So the SGLT2 receptor is a receptor in the kidney. And so by blocking that, it helps excrete glucose. And so if you think about if somebody has very high glucose levels, if the kidney is excreting more glucose, that really what the main focus would be is reducing glucose levels. There are actually receptors in the heart as well. And so because of that, the inhibitors are able to also promote favorable cardiac remodeling. And that's what we think helps prevent heart failure.
Yeah. So that initial kind of diuretic effect and then some remodeling effects down the road, as well as you said, beneficial effects on the kidneys. Yeah, really remarkable story, remarkable class of drugs. And as you mentioned, not only preventing heart failure, but actually preventing cardiovascular mortality as well. And these are not small effects. And so they do seem to be additive. Who needs an SGLT2 inhibitor today in 2021?
2021, and then I'll tell you who I think will be in the future.
There you go.
2021, we've got great data now in heart failure, both with preserved and reduced ejection fraction, chronic kidney disease, diabetes, and individuals who do not have diabetes but have risk factors for specifically having heart failure with reduced ejection fraction, preserved ejection fraction, or chronic kidney disease. I think in the future, as we get there, even individuals who don't have diabetes but are at high risk for heart failure may benefit, because like you said, the signal hasn't been small. It's been a 30% reduction almost consistently in every trial to prevent heart failure.
One of the nice things about this class, I think, also is they're remarkably safe, right? They don't cause hypoglycemia because they just take the excess glucose that's being spilled out and prevent the reabsorption of it. And they also get rid of some extra sodium while they're doing that. So, can you talk a little bit about the side effects that we see?
Yeah, that's been a challenge. I do think that as we've started to prescribe these drugs, one of the things that we want to be careful about is that we are talking about potential side effects. In the early studies, there was a signal towards risk for amputation, especially in patients with uncontrolled diabetes. There's been a risk for urinary tract infections and genital infections. And so that's important to talk about before prescribing them as well.
Yeah, absolutely. And it makes sense, right? More sugar in the urine, more likely that there can be genital and urinary infections. So, but overall, remarkably safe drugs. And again, the thing we would worry about most would be the hypoglycemia. Just doesn't really happen very often at all, which is nice to see. So maybe the drugs of the future, which is great. Terrific. Well, I want to thank you both for a really rich and wonderful discussion. We're gonna pivot now to some of the questions that were submitted beforehand, but also I see a couple in the Q&A during the chat so far. Let me encourage our participants or listeners to go ahead and put any additional questions in the Q&A. We'll take a look at those and we'll try to get to as many as we can. Neal, I'll start with you. Not surprisingly, many of the previously submitted questions and the two that we have so far in the Q&A are about diet. And, plant-based, what are the risks of animal fats? And is there a best diet for everybody, or does it really need to be tailored to someone who has hypertension or someone who has dyslipidemia? What are your thoughts about that kind of big picture diet?
Yeah. So the answer is, I think it can be done, but everybody should realize that there used to be different diets. There were carbohydrate sensitive people. There were people who were more fat sensitive in the effect that the really low saturated fat diet made a big difference to LDL. This was the basis of the NIH diets. I was at the National Heart Institute with Doctors Fredrickson and Levy from 70 to 73, and we had 5 different diet books. Then I wrote a little book, which is no longer there. It was it didn't last very long, but it was called Fat Chance. And it said there's a diet for people with really high LDL that's got low dietary cholesterol, low saturated fat. There's a book for people with big abdomens, high triglyceride, low HDL, borderline sugars. This, of course, was the metabolic syndrome. I wasn't smart enough to call it that until another 30 years. But that diet required a higher fat level so we could reduce the carbohydrates more. And then, of course, a severely low fat diet for those with triglycerides in the thousands. Well, all of these came together when we realized that we could take a Mediterranean style diet and we could just make a few little additions. We would say, instead of high fat meats, we would go more with fish and skinless poultry. Instead of dousing everything in a lot of butter and hard fats, we could use extra virgin olive oil, canola oil. We had data on both of those that was good. And before long, it was possible to try to merge those diets. And one of the problems with the so-called low-fat diet is the American Heart Association was actually never for a very low-fat diet. The less than 20% diet that some people like Dean Ornish espoused was actually turned down. And there was always factors that said, let's not get too aggressive about that you want to have people have plenty of room to be able to restrict their carbohydrates, because unfortunately, if you take all the fat out, but there are good fats, the unsaturated fats and the monounsaturated fats that can be part of a good diet. But that still means that you don't want to have the French fries and the cheeseburgers that really were part of the American diet and were not healthy.
Yeah. I think, Neal, that's a great way to put it. What I talk with my patients about is as time has gone on, as you indicated, things have actually gotten simpler because we started to talk about foods and eating patterns rather than nutrients. How much cholesterol is in your diet? Well, sometimes that's hard to know, right? How much sodium is in your diet? Sometimes that's hard to know. For almost everybody in the population, right, a prudent diet is going to look like that Mediterranean diet you described, or the American version, which we often call the DASH diet, right? The Dietary Approaches to Stop Hypertension diet. And the core elements of these eating patterns are the same, right? It's really a lot about plant-based foods, right? Lots of fruits and vegetables. The proteins that you eat should be lean, and any sort of carbohydrates you eat should be high in fiber. And that's really it. If you eat food that looks like food and you follow those general guidelines, and avoid the processed stuff that has been pre-prepared for you and bagged or canned, or not eat out in restaurants too much where it's going to be very calorie dense, you're going to do just fine, 98+% of the time. Now, there are, certain conditions, I think, where people have to be particularly prudent, but those general guidelines will serve the vast majority of the population well. Would you agree with that guidance?
Absolutely. I think that's what we've tried to point out, that the arguments about, like you say, the nutrients, as opposed to talking about dietary patterns, that's been the big step up. I think that was a great point, Don.
Yeah. And I think, as you said, there are healthy fats, and, having a handful or two of almonds or nuts, is a good thing. And making sure you're cooking in those healthier fats, the canola oil, or adding the raw olive oil onto your salad, or dipping your whole grain bread into the raw olive oil, that's great. That will be healthy again for the vast majority of people. And I think if we get people to step back and not look at the micronutrients, but think about the macro and the eating pattern that they're pursuing, I think almost everybody does better. And there's really good data for those kinds of eating patterns for both preventing recurrent heart disease events, the Leon diet heart study, preventing primary events, right? The studies done in Spain, and then even reducing blood pressure in the DASH trials. And again, all the diets that were pursued there largely have the same backbone. So it doesn't have to be as complicated, I think, as often the media tries to make it be.
Yeah, I like to emphasize that we probably agree more on what's a good diet than we disagree.
Yeah.
If you talk to people who are cardiologists and who deal with the health of their patients, we're all agreeing on the core parts of the good diet, where the disagreements really should not be part of the conversation. I think they really confuse patients greatly.
Yeah, I would totally agree with that. Sadia, let me turn to you with some of these questions, and they're really rolling in now, which is terrific. So let me I'll ask you this one first, and maybe I'll generalize it. So there are a couple questions about the use of biomarkers, things like high sensitivity CRP, or some of the imaging tests that we use to try to help select people for, let's say, a statin, or maybe someday for an SGLT2 inhibitor. Does everybody need a CRP? Does everybody need a coronary calcium score? How do you use those things in your practice?
I think that's a great question. And it's been one of the things as we develop more and more tools, biomarkers, genetics, imaging like coronary artery calcium, echocardiography. Do we really need to apply them to everybody, or do we need to identify who may benefit from that further personalization or risk stratification? And I think the ACC/AHA guidelines from a couple of years ago did a really nice job and came up with the algorithm that you labeled CPR now to avoid CPR later. Very catchy, right? To look at this kind of step-by-step approach. So, and CPR stands for calculate, personalize, and reclassify. And so thinking about that calculation, or the initial step, using the ASCVD or pooled cohort equation to look at the traditional risk factors, you might be able to get there with the information you have right in front of you, looking at blood pressure, looking at diabetes status, looking at a person's age. And so if that already tells you that somebody's high risk, then these additional tools aren't really going to do much more. If you already know that somebody may benefit from a statin, then I think you're there. If you already see that somebody is very low risk, they have no hypertension, they have a really healthy diet, you've been able to talk with them and understand what their risk is right now, and it's calculated to be very low, and these additional tests probably aren't going to make much difference either. It's really the people in the middle. And I think that's where we've seen the most utility of these additional biomarkers. High sensitivity CRP hasn't really panned out that much because it tracks with risk. And so that's where we haven't seen much benefit for it. And I don't use that in my practice. But I do think some of the other tests like coronary artery calcium using echocardiography can be very useful in that intermediate risk group.
So that's that reclassification step, right? And how does it push you? You know, what amount of coronary calcium, or what amount of left ventricular hypertrophy would make you do something different? Would help you change your decision in one of those kind of intermediate risk on the fence patients?
Yeah, I think for coronary artery calcium, it's much clearer. And I've been talking a lot about echocardiography and thinking about the intermediate risk patient there, but that's where we have less evidence. And we definitely need to learn more about what's the right degree in which using echocardiographic markers could help us intensify prevention for heart failure. So if we shift back to ASCVD, where I think we've got a lot of great data and guidance, looking at coronary artery calcium, we can actually calculate percentiles. So how much coronary artery calcium is to be expected. We also know there are several cutoffs. Greater than 400 especially is a high risk patient. And so those are things that I look for to say, if I'm looking and we're seeing a lot of calcium or more calcium than expected for somebody's age, then that's a discussion again to have with the patient to think about why a statin specifically or other therapy may be helpful.
Perfect. Neal, a couple of questions about lipoprotein little a. Do you want to give us a quick primer on lipoprotein little a and some of the excitement around potential new therapies that finally might both treat the Lp(a) and actually reduce heart attacks and strokes, which at the end of the day is what I think we're trying to do, right?
Right. Well, Lp(a), I think, is finally gotten to the point where most doctors have heard about it, and it's a special biomarker that tells you that if it's high enough, you have increased risk. Now, unlike cholesterol and blood pressure, where if a little bit gives a little bit of risk and a little more gives more risk, you've got to get to higher levels of Lp(a) before you actually see the effect on risk. The problem with Lp(a) is that we don't have a specific therapy for it, as you alluded to. We've got this great research, which we hope will give us that therapy, but we don't have a specific therapy. So our guidelines said that Lp(a) was a strong enhancing factor, and especially in people with a family history of coronary disease. So a person with a personal or family history of coronary disease, the Lp(a) points out maybe why they have that higher and earlier risk. And what we're hoping at, because we don't have current therapies, is eventually we'll get some of these anti-sense inhibitors that'll go into the liver and knock out the production of Lp(a), because you've got to drop it 70, 80%. Just knocking Lp(a) down 5% with some over-the-counter niacin isn't going to do the trick. And a lot of people are confused about that. People also need to know that we've got to measure Lp(a) better. And we're working on FDA-approved assays to do a better job than what we have now. And lastly, we need to be mindful that there are ethnic and racial differences. An Lp(a) in someone who's African American, someone who's Japanese American, or someone who's a Caucasian American, the same number will give them a different percentile. And so we have to be a little bit careful here before we get into one size fits all. But the new day is coming. We're coming up with better ways to measure it and better ways to lower it.
Yeah, totally agree. I think we are at the point where there is good consensus that this is a causal risk factor. It's an additional protein that sort of enhances the potency of your LDL particles to make plaque. And that if we could get a directed therapy that knocks that out or neutralizes it or prevents the production of the protein, as you said, we are likely to see less atherosclerosis and fewer events. I think we need the trials to prove it, but those trials are actually underway now. So we're hopeful that we're going to see that. As you pointed out, niacin was used to lower Lp(a) levels modestly, but it has not actually been shown to reduce events. And that's the problem. And niacin, as we've seen, also has its own problems with side effects, including maybe excess mortality, but certainly excess bleeding, excess flushing, and excess GI events. So not a great drug, and certainly not in favor anymore as anything like a first, second, third, or fourth line therapy. So we've certainly changed our thinking about that one. So we're getting close to the top of the hour. Sadia, real quick answer from you. Is there a cure for atrial fibrillation?
I think the
one word answer. One word answer.
Lifestyle.
Well, is there a cure once atrial fibrillation has developed?
I think ablation could be as close a cure that we have.
Yeah, maybe.
But
doesn't get you off the hook right entirely. And we know that the lifetime risk of atrial fibrillation is roughly 1 in 4. So this is a very common problem. It is definitely something I think we're going to be spending a lot more time thinking about how to prevent, how to treat, and better ways to try to get to a cure so that patients don't have to continue to take the blood thinners. But yeah, completely right. Totally agree with you. There was a question about Dr. Stamler and someone reminiscing about some political things. And you saw in the video we alluded to the fact that, people have attacked his science all along. I want to share a story that many of you may know about Dr. Stamler, but many of you may not, and this I think is a testament to the character of Dr. Stamler. So as many kids did at his age, he had friends who were members of the Communist Party when he was growing up in the 20s and 30s. And so when McCarthyism came in the 50s and 60s, he was actually called to testify in front of the House Un-American Activities Committee. And this may be what the questioner was thinking about. You had two choices in those days. You could either take the fifth, which was an indicator of guilt in many people's eyes, and you were blacklisted and you lost your job, or you could roll over and provide names to the committee and you were blacklisted and lost your job. Dr. Stamler, to his credit, worked with friends here in Chicago who were lawyers, and they chose a third way. And they decided to contest this and actually go to court and say that this was unconstitutional to make people answer these questions. And Dr. Stamler actually pursued his case, was held in contempt of Congress, but pursued his case all the way to the Supreme Court twice. And the Supreme Court ruled in his favor. And that broke the back of the House Un-American Activities Committee and essentially disbanded that committee because it was felt to be unconstitutional in terms of what they were pursuing. So again, that is to me moral courage that I think is sorely lacking in too much of our society these days. But it really, I think, for me, is a measure of the man. And I think you've seen not only is he a remarkable human being and a remarkable scientist and clinician, but again, that sort of moral courage, I think, is really quite remarkable. So I want to finish then with one last question, because this is an alumni event. And Neal, let me ask you, how does philanthropy help support your work? How has it impacted the research you've done in prevention? And what do you think about the role of philanthropy in driving our ability to do good science?
Yeah, thanks, Don. Well, I've been very fortunate. I've had numerous patients who have contributed generously to Northwestern. And what I always say to them is how proud I am of that, because in a way they're sharing my enthusiasm for making this a better medical center. But more importantly, as our dean likes to point out, creating that better tomorrow. Do we really want to have today's science to be tomorrow's science? No, we want tomorrow's science to be much, much better. And because of really the incredible generosity, that new research building is an example, the Galter Pavilion, the Feinberg Pavilions, these are examples, the Bloom Cardiovascular Institute. And I can't name everybody, but just to point out just a few people who've made a huge difference, and people with even much lesser contributions have made a difference to various research funds for all of us, including myself. And what they've done is allowed us to spend our time working to make that better tomorrow, which benefits not just humanity or the US, but it really benefits those who live next to Northwestern, who can take part in a vibrant culture where you can meet clinicians who are looking to do things in terms of helping you medically that, frankly, a lot of other places just are not getting to. And so this has become a very special place, really rivaling all the top 10 medical schools, which all do similar things. I don't want to claim we're better, but we're certainly among all of those who really go that extra mile to make sure we have a better tomorrow. And that's why I hope everybody will share my enthusiasm for Northwestern and think about us if you have a philanthropic bent.
Yeah. Thank you so much, Neal. And I know we're at the top of the hour, but Sadia, I'd love people to hear a little bit about what are the frontiers in your research? What are you focusing on these days? And what would help get you to that brighter future?
Yeah, I think, as Neal said, someone who's also benefited from philanthropy, it's been really critical at those time points, especially early on in a career where you're just trying to make that transition, especially during fellowship and right when you graduate. It's the small pilot studies and being able to inject funding into ideas that maybe sound crazy in the beginning, need to be vetted, need to be developed. And being able to have the opportunity to do that, I think, is really remarkable and is a testament to the institution, and I think to that investment in early career and young faculty. In terms of what I think could really be the next frontier is building upon what we've talked about, really personalizing risk stratification. So where we still are is using the basics in terms of risk estimation, but being able to really shift to more of a precision medicine or precision health approach. And so integrating these tools that we use in the research setting, genetics, genomics, metabolomics, proteomics, but we need to figure out how to transfer them into the clinical setting. So I think those are really exciting avenues to think about how we can prevent disease and eradicate disease using those tools. I know that's a really broad overview, and a lot of what I have learned, I credit to both you and Neal as well. But I'd like to turn it over to you to end the hour and think about, your legacy and impact at Northwestern, but also nationally, internationally, and the realm of cardiovascular health is incredible. But what do you think is really the next frontier?
Well, thanks, Sadia. Working at a place like this with mentors and colleagues like Neal, as I said, who I get to carpool with and pick up absolute gems of pearls, and having incredibly exciting young investigators like yourself, creating those new ideas. They're not crazy. They are, right at the cutting edge, and they're critical to push our science forward. So I feel so fortunate to work in a place like this. For me, and you know this well, Sadia, as my career has gone on, I've gone from studying middle-aged people with risk factors and understanding their outcomes to then studying young, healthy adults and understanding how they become maybe not so healthy middle-aged people. For me, the current frontier is really understanding what are the events in early childhood that launch us into trajectories of cardiovascular health that really, affect us lifelong. And even, and this is some work we share together, what are the events that occur in utero that start to program us for certain types of cardiometabolic health? And so the exposures that happen in utero that can actually change the epigenome, not the DNA code itself, but how we can actually transcribe our DNA code, our genes, that actually can affect us lifelong. And it's a really incredibly exciting, area of research, because it really does launch that perspective that there is a life course of cardiovascular health, and that we need to understand much better how to take healthy mothers and fathers, generate healthier babies, and keep them healthy really into adolescence and young adulthood, because that's going to be the key to long-term success. So we need every stage here. We've talked about tertiary prevention. We've talked about secondary prevention. We've talked about primary prevention. For me, the frontier right now is primordial prevention, not letting people lose the cardiovascular health they're born with, and not letting them develop the cardiovascular risk factors in the first place. So maybe with that sort of long-term perspective, and again, I think you see here 3 generations of legacy of Dr. Stamler's work that have influenced all of us so remarkably. And I want to thank all of you for staying a few extra minutes, but I want to thank everybody for attending tonight's webinar. You will be receiving a follow-up email with a link that you can use to look at the recording. So whether you were able to attend all of it or just some of it, you can watch it again at your leisure if you'd like to. And we're just so grateful that you had the interest to ask about Dr. Stamler, to think about preventive cardiology, and to be with us here this evening. So I hope everyone has a great night. Let me thank Dr. Stone, Dr. Khan, and all of our participants, and be safe out there, please.